Imagine your immune system as this highly trained army,
Yeah.
just endlessly patrolling your bloodstream.
Right, yeah, constantly on the lookout.
Exactly. And it is fully capable of recognizing and wiping out cancer cells.
Yeah.
But in the case of advanced lung cancer, well, the tumor has often figured out how to wear this like invisibility cloak.
It's a great analogy, really.
So the immune system's T cells, they just walk right past it, completely unaware of the threat.
Yeah.
And today, we are looking at the medical playbook that teaches doctors how to strip that cloak away.
Yeah, we are diving deep into the ESMO Clinical Practice Guideline. That's the European Society for Medical Oncology.
Right.
And this specific document, I mean, it's basically the global master strategy for treating metastatic non-small cell lung cancer. But we're focusing entirely on a distinct subcategory today, cases without a driving oncogene mutation.
Which is an important distinction, right? Because when a lung cancer has a specific genetic driver, like a singular identified mutation, doctors can often just prescribe a targeted pill to shut that specific mutation down.
Exactly. You find the target, you hit the target.
But when it doesn't have that single target, the cancer isn't reliant on one, easily cut power line.
Mm-hmm.
The playbook has to change entirely.
It really does. And whether you are a medical professional trying to synthesize the latest protocols, or maybe a patient navigating a new diagnosis, or even a caregiver trying to decipher what your medical team is planning, our goal today is to decode the complexity of these options for you.
Yeah, we're going to break it down.
We are not just going to map out what treatments the top oncologists choose. We are going to explore the underlying biological mechanics of, why they choose them.
Okay, let's unpack this by starting where every oncologist has to start, which is the detective work.
The absolute first step.
Right, because you cannot effectively fight an enemy you haven't thoroughly identified.
Yeah.
But the stark reality of stage IZ lung cancer is that doctors are often forced to build this master battle plan based on a shockingly microscopic amount of evidence.
Yeah, I mean, when lung cancer reaches stage 4, it has spread beyond the primary site. So surgery to remove the whole tumor just isn't an option at this stage.
Right, you can't just cut it all out.
Exactly. So the only tissue samples available are typically acquired through these really small biopsies. An interventional radiologist or pulmonologist, they use imaging to guide a very thin needle into the chest to extract just a tiny cluster of cells.
And from that literal millimeter of tissue, pathologists have to make the first major triage decision. They rely on the World Health Organization's 2021 guidelines to classify the cancer's histology.
Which basically means looking at the physical architecture and the origin of the cells.
Right, and the very first fork in the road is determining if the tumor is squamous or non-squamous, like an adenocarcinoma.
And that structural distinction is critical because it dictates completely different drug pathways later on. But beyond just looking at the shape of the cells, the ESMO guidelines mandate an absolute necessity.
The biomarker testing.
Yes, testing all stage IV cases for a specific surface protein called PDL1.
Okay, and this is where that invisibility cloak comes in. I always picture the PDL1 protein like a VIP bouncer for a very exclusive nightclub.
Oh, that's a good way to look at it.
Because normally the T cells in your immune system, they patrol the body looking for rogue cells to destroy. But some of these lung cancer cells, they cover their outer membrane in this PDL1 protein.
Right, they coat themselves in it.
Yeah. And when the T cell approaches, that PDL1 protein binds to a receptor on the T cell. It's essentially flashing a VIP badge that says, nothing to see here, we belong in this body. And the T cell gets the stand-down signal and literally just walks away.
It's a brilliant, albeit terrifying, evolutionary trick by the cancer. So the pathologist's job is to figure out exactly how many of those VIP bouncers are standing outside the club.
So they count them.
Essentially, yeah.
Yeah.
They score the tumor based on the percentage of cells showing the PDL1 protein on their membrane. And to ensure statistical accuracy, the guidelines state the pathologist needs a minimum of 100 accessible tumor cells in that tiny needle sample.
Wow, just 100 cells.
Yeah, and they report the score in 3 distinct tiers. You have less than 1%, between 1 and 49%, and then 50% or greater.
But the actual, the chemical process of counting those proteins isn't just one single universal standard, right?
No, not at all.
Because the guidelines list a whole fleet of different assays, these chemical dyes that labs use to find the PDL1. You see clones listed like 22C3, SP263, 28Z8, and SP142. I mean, it sounds like a lineup of droids from Star Wars.
It really does. But what's fascinating here is how the molecular affinity of these different assays directly impacts the diagnosis.
How so?
Well, these assays are essentially engineered antibodies designed to latch onto the PD-L1 protein and stain it so the pathologist can actually see it under a microscope.
Okay.
And comparative studies have shown that 22C3, sp263, and 28-8, they all have very similar binding affinities. They are effectively interchangeable.
But the last one isn't.
Right. The sp142 assay is biologically different. It stains not just the tumor cells, but also the immune cells that are infiltrating the tumor. Yeah, which fundamentally changes how the score is read. And this is exactly why the guidelines demand such rigorous internal and external quality assurance.
Because if they mess up the dye.
Exactly. A slight miscalibration in the lab's chemical dye could literally drop a patient from, say, the high 50% tier down to the 40% tier, which completely alters their treatment options.
Okay, I have to push back on this whole biopsy process for a second.
Yeah.
We're taking a tiny needle sample, isolating maybe 100 cells, and staining them with these complex assays.
Mm-hmm.
But human tumors are notoriously chaotic, right?
Yeah.
They are not perfectly uniform blocks of identical tissue.
No, they definitely are not.
So if a tumor has different genetic characteristics in different areas, how do we know the needle didn't just snag a weird, unrepresentative corner of the cancer?
It's a great point. Tumor heterogeneity is arguably the greatest diagnostic challenge in modern oncology. You are completely right to question it.
So how do they avoid making a huge mistake based on a bad sample?
Well, to mitigate the risk of flying blind, the guidelines highly recommend ROSE. That stands for Rapid On-Site Evaluation.
Wait, so the pathologist is actually in the room during the biopsy?
Essentially, yes. While the needle is still in the patient, the extracted tissue is immediately smeared onto a slide, stained in seconds, and evaluated under a microscope right there in the suite.
That is incredible.
It really is. The pathologist can instantly tell the interventionalist, hey, you only hit dead necrotic tissue, or you only got healthy lung cells, redirect the needle.
So they know they have a good sample before the patient even leaves the room.
Exactly. It ensures that the microscopic sample eventually sent for that crucial PD-L1 testing is actually viable, metabolically active tumor.
Okay, so the detective work is sound. We have the histology, we know if it's squamous or non-squamous, and we have an accurate PD-L1 score. Now we transition to the frontline arsenal.
The treatment phase.
Right. And we were looking at patients who are in relatively good health, what the medical world calls a performance status of 0 or 1, meaning you're fully active or at least able to do light work.
Correct.
So if a patient has a PD-L1 score of 50% or greater, they have a massive amount of those VIP bouncers. Can we just strip the bouncers away and let the immune system do the rest?
We can. For that high-tier, single-agent immunotherapy is the standard of care.
Just the immunotherapy?
Yes. We use a class of drugs called checkpoint inhibitors medicines, like pembrolizumab, atezolizumab, or semiclomab.
And those don't kill the cancer directly, do they?
No, they don't. They are engineered antibodies that physically block the PD-L1 protein. They rip the invisibility cloak off.
Wow.
And suddenly, the patient's own T cells recognize the massive tumor as a foreign invader and initiate a brutal, entirely natural immune response.
Which leads to a logical deduction.
Yeah.
If the tumor's PD-L1 score is lower, say between 1 and 49% or even less than 1%,
Yeah,
there just aren't enough of those bouncers for the checkpoint inhibitors to target effect.
exactly right.
So just ripping the cloak off isn't enough to wake up the immune system in those cases. We have to bring chemotherapy back into the mix, right?
Yes, we do. For those lower tiers, the standard is a combination therapy. We administer traditional platinum-based chemotherapy simultaneously with the immunotherapy.
So they work together.
Right. The chemotherapy acts as the battering ram. It physically shatters the cancer cells, causing them to spill their internal proteins into the bloodstream.
Oh, I see.
And this massive release of cellular debris acts like a flare gun for the immune system. It draws the T cells to the area, while the immunotherapy ensures those T cells don't get turned off when they finally arrive.
But there is one highly specific exception in the ESMO guidelines that caught my eye. They note that using immunotherapy all by itself, monotherapy, is noticeably less effective in patients who have never smoked.
Yes, that's a very important nuance.
And they define never smoked
Yeah.
very strictly, right?
Yeah.
Like less than 100 cigarettes in an entire lifetime. Why would a healthy non-smoker's lung cancer resist this amazing immune treatment?
It comes down to a biological metric called tumor mutational burden, or TMB.
Okay.
Cigarette smoke is packed with carcinogens that severely damage DNA, Over decades, a smoker's lung cancer accumulates thousands of distinct genetic mutations.
Because it's just getting bombarded with chemicals.
Exactly.
Yeah.
And because the DNA is so mangled, the proteins the cancer cell produces look wildly alien. Once the immunotherapy removes the invisibility cloak, the immune system easily recognizes these highly mutated, alien-looking cells and attacks.
So a non-smoker's tumor is almost, well, too normal looking.
Precisely. A non-smoker's lung cancer is typically driven by a more subtle, singular cellular error, not decades of massive chemical damage. So the tumor has a very low mutational burden.
And the immune system just doesn't see it as a threat.
Right. Even when the invisibility cloak is removed, the immune system inspects the cancer cell and essentially determines that it doesn't look alien enough to destroy. It's less immunogenic.
That makes total sense.
Therefore, for never smokers, the guidelines strongly lean toward adding chemotherapy to physically damage the tumor and artificially spark that necessary immune response.
Now, here's where it gets really interesting to me. If combining chemotherapy as a battering ram with immunotherapy works so well across the board, why wouldn't a doctor use that combination for the high PD-L1 group too?
That's a common question.
Because if the tumor is already highly susceptible to the immune system, why not hit it with absolutely everything we have, chemo and immune drugs together, just to be sure?
If we connect this to the bigger picture, oncology is never solely about eradicating the disease. It is just as much about preserving the host.
Okay, the patient's quality of life.
Exactly. When you analyze the massive clinical trials for patients with a PD-L1 over 50%, the 24-month overall survival rates are remarkably similar whether they receive just the immunotherapy or immunotherapy plus chemotherapy.
Wow, really? So the survival destination is the same, but the journey to get there is vastly different.
Perfectly said. Chemotherapy is inherently indiscriminate. It attacks any rapidly dividing cell in the body. That brings profound collateral damage.
Right. The classic side effects, nausea, hair loss.
Yes, bone marrow suppression, severe fatigue. If you can achieve the exact same 2-year survival rate using only a drug that harnesses the patient's natural immune system, you spare them the immense physiological toll of the chemotherapy.
So it's a calculated restraint. But what happens if we are forced to abandon the immune system entirely?
Right, which does happen.
Say a patient has a severe autoimmune disease like lupus, where stimulating the T cells would cause their body to attack its own organs. Or what if they started immunotherapy and the cancer eventually mutated to resist it?
Then we have to shift to Plan B.
We move away from the modern playbook and back to the classic, refined chemotherapy options.
Exactly. When immunotherapy is contraindicated or fails, the cornerstone of the ESMO guideline is a platinum-based doublet.
What does that mean exactly?
This means combining a heavy metal drug, either cisplatin or carboplatin, with a third-generation chemotherapy agent, like gemcitabine or a taxane.
I want to break down those third-generation agents for a second because the guidelines list them without much context. What makes them third-generation?
Well, first-generation chemotherapies in the mid-20th century were blunt alkylating agents, very raw. Second-generation drugs in the 70s were slightly more targeted. The third-generation agents emerged in the 90s with highly specific mechanisms of action.
Oh, okay. Like what?
Take taxanes, for example. They were originally derived from the bark of the Pacific yew tree, actually.
Really? A tree?
Yeah. And they work by physically paralyzing the cancer cell's internal skeleton, the microtubules. The cell gets stuck trying to divide and eventually triggers its own death.
That's incredible. And the other one, gemcitabine.
Gemcitabine takes a different route entirely. It disguises itself as a normal building block of DNA. When the cancer cell tries to copy its genome to multiply, it incorporates the gemcitabine, which essentially jams the DNA replication machinery completely.
And those are paired with the heavy metal platinum drugs. But the choice between cisplatin and carboplatin isn't just a coin flip, is it?
Definitely not.
The guidelines are adamant about tailoring the choice to the patient because they have vastly different side effects. Cisplatin causes notorious severe nausea and vomiting, while carboplatin is much rougher on the blood counts, causing thrombocytopenia.
Right, a dangerous drop in platelets.
So why do two similar heavy metals act so differently in the body?
It is entirely due to their chemical leaving groups. Cisplatin's molecular structure causes it to violently damage the DNA of the rapidly dividing cells lining the gastrointestinal tract.
Oh, wow.
Yeah, so those damaged gut cells panic and release massive amounts of serotonin, which travels up the vagus nerve and directly hits the vomiting center in the brain.
That sounds awful.
It's very difficult for patients. Carboplatin, however, was engineered with a different molecular structure to make it far more stable. Because it's stable, it doesn't break down in the gut as much, sparing the patient the extreme nausea.
But there is a biological cost to that stability, right?
There is. Because carboplatin is so stable, it circulates in the bloodstream much longer. It eventually accumulates heavily in the bone marrow, where it suppresses the megakaryocyte cells responsible for producing blood platelets.
So the doctor really has to weigh the risks.
Exactly. The oncologist has to look at the patient sitting in front of them. If the patient already has a compromised bone marrow, carboplatin is a massive risk. If they have a history of severe gastrointestinal issues, cisplatin is the danger.
There is also a major unbreakable rule in the chemotherapy section that I saw. The drug Pemetrexed is strictly restricted to non-squamous cases.
Yes, strictly.
It does not matter if it's the frontline therapy or the third line. You absolutely do not give Pemetrexed to a squamous cell lung cancer patient.
And this circles perfectly back to our initial detective work. Squamous cell carcinomas inherently produce massive quantities of an enzyme called thymidylate synthase.
Okay.
Pemetrexed works by trying to inhibit that exact enzyme to stop DNA synthesis. But the squamous cancer cells have so much of it naturally that they simply overpower and neutralize the drug.
Wow, so it would just be useless.
Worse than useless. If you get the histology wrong on day one, you will deliver a completely ineffective, highly toxic drug for no benefit.
Okay, so assuming we have the right drugs, the guidelines heavily stress treatment caps. They mandate stopping the aggressive platinum doublet after 4 to 6 cycles.
Right.
After that, they drop the heavy metal and transition the patient to maintenance therapy, keeping them on just one lighter drug, like Pemetrexed. I sort of view maintenance chemotherapy like keeping your foot on the gas pedal just enough to maintain highway speed without blowing out the engine.
That's a very accurate way to frame it.
But if the cancer is shrinking at cycle 6, why pull back your strongest punch?
This raises an important question about the fundamental nature of cancer evolution. Chemotherapy is a selective pressure. In the first few cycles, you eradicate the vast majority of the susceptible tumor cells.
Okay, so the easy ones die first.
Exactly. But the cells that survive 6 cycles of platinum chemotherapy are the genetically resilient, highly resistant clones. Continuing to hit them with cycle 7 or 8 yields severely diminishing returns.
You just won't kill much more cancer.
Right. However, the cumulative toxicity on the patient's bone marrow and kidneys increases exponentially. Stopping at 6 cycles is the scientifically proven threshold where the biological cost finally exceeds the chemical benefit.
Okay, so we built a comprehensive battle plan for when the cancer's everywhere. But what happens if the primary tumor has only sent out a few isolated scouts?
Ah, right.
That brings us to our final frontier, the edge cases. Specifically, oligometastatic disease.
Yeah, oligo simply means few. The ESMO guidelines define oligometastatic disease as having up to 5 metastatic lesions total.
So the cancer has escaped the lung, but it hasn't exploded systemically.
Exactly. You might have the primary lung tumor and perhaps 2 isolated spots in the brain or maybe a single nodule in the adrenal gland.
And the strategy here pivots completely. Instead of just relying on systemic drugs to wash through the whole body, the guidelines strongly recommend integrating local radical therapy, or LRT.
Yes.
That means sending a thoracic surgeon in to physically cut out the metastasis, or using something like stereotactic ablative radiotherapy, ABR, to destroy it. How does ABR differ from the standard radiation most people picture?
Well, standard radiation typically involves delivering small daily doses of radiation over 6 to 7 weeks. You're hoping to damage the cancer slightly faster than the surrounding healthy tissue.
Right, the traditional approach.
SABR is entirely different. It uses highly advanced imaging to track the tumor's exact position even as the patient breathes.
Oh, wow.
It then fires multiple highly focused beams of radiation from different angles that all intersect exactly at the tumor. The intersecting point delivers a massive ablative dose, literally burning the tumor away in just 3 to 5 sessions.
That's wild. And the healthy tissue.
The tissue along the path of any single beam receives a minimal, safe dose. Only the tumor gets the massive hit.
So what does this all mean for the patient? I actually want to challenge this rigid guideline definition for a second. They define oligometastatic as up to 5 lesions.
Yes, that is the number.
Is human biology truly counting to 5? I mean, what happens if a patient has 6 tiny millimeter-sized spots versus another patient who has 4 massive aggressive tumors? Is the patient with 6 totally disqualified from this life-extending local therapy just because of an arbitrary number?
It's a fantastic point, and this is exactly where rigid clinical trials clash with the messy reality of human biology. The number 5 is not a biological absolute. It is a pragmatic line drawn in the sand by researchers.
Because they have to draw a line somewhere.
Exactly. If you don't set a strict limit during a clinical trial, the data becomes impossible to standardize
So the guideline acknowledges that limitation.
explicitly. And to prevent a patient from being penalized by a rigid number, the guidelines mandate that every single patient with limited spread must be reviewed by a multidisciplinary tumor board, or MTB.
So you get a whole team on it.
Right, you pull the medical oncologist, the radiation oncologist, and the surgeon into the exact same room. They don't just count spots on a scan. They evaluate the location, the trajectory, and the sheer volume of the disease.
So 4 large tumors wrapped around a major artery might be ineligible.
Exactly. While 6 tiny spots in safe locations might be perfectly treatable, the board ensures the human element overrides the algorithm.
And speaking of the human element, the guidelines carve out specific paths for vulnerable populations. Like for patients with a performance status of 2, meaning they are fatigued, spending up to half their day resting, but still capable of self-care.
Right.
The data confirms that tailored chemotherapy is still vastly superior to simply providing palliative, best supportive care for them.
It is. And the same careful calculus applies to elderly populations, generally those over 75. They follow the same broad guidelines, but the data is far less decisive on whether adding the heavy toxicity of chemotherapy to their immunotherapy actually provides a survival benefit that justifies the physical toll.
So it's very individualized.
Very much so. Every single decision in this massive ESMO document is a calculated attempt to maximize the duration of life while profoundly respecting the physical limits of the human body.
And that brings our deep dive full circle. We started in the microscopic world, seeing exactly how critical it is to establish histology and hunt down those PD-L1 VIP bouncers using precise chemical assays.
Right.
We explored the mechanistic balance of unleashing the immune system alone versus using chemotherapy as a battering ram to expose the cancer. And we've seen how doctors map out entirely different strategies for isolated oligometastatic scouts versus widespread systemic disease.
Yeah, and the true value of absorbing a dense guideline like this isn't, to walk away with a medical degree.
No, definitely not.
It is about gaining the vocabulary to be an active partner in your own strategy. You can sit across from your medical team and actually ask, hey, what specific clone assay was used to determine my PD-L1 score? Or has my specific scan been reviewed by the multidisciplinary tumor board to evaluate stereotactic radiation?
It fundamentally changes the dynamic in the clinic. And as we wrap up, I want to leave you with one final fascinating biological mystery buried near the end of the guidelines.
Oh, yes. This is a good one.
The document notes that for most of these frontline strategies, if a patient is responding well, immunotherapy can actually be safely discontinued after 2 years, even if there is absolutely no sign of the disease progressing.
Yeah, and the recommendation to stop is driven by the fact that the cumulative risk of long-term autoimmune toxicity, where those hyperstimulated T cells eventually decide to attack your healthy organs, well, it starts to outweigh the oncological benefit.
But think about the profound biological implication of that.
Right.
I want you to ponder this as you go about your day. What exactly is happening inside the immune system at year 3? When the synthetic antibodies are completely flushed from the bloodstream?
It's the ultimate question.
Does the body's native immune system actually remember how to recognize and fight the cancer on its own after the pharmaceutical training wheels are taken off? We might be actively witnessing the scientific threshold where advanced metastatic lung cancer transitions from a universally terminal illness into a manageable chronic condition that your own body has finally learned to keep in check.